teratogenicity, all those things. So that will be just a repetition. So, but all those things, what we have already discussed regarding the different trimesters can be asked for you again in the exam. So even when you are presenting a short case of pregnancy with anemia, so that you should always remember, and then you should try to tell if there is any, anything positive there. Like in your particular history, there was a positive history of patient having hyperemesis gravidarum and admitted to the hospital the first trimester. So that itself is a very important thing because of that only now of the iron tablet patient may not be taking properly. So that might have produced, or one of the factors which might have influenced her developing anemia. Other than other factors like repeated pregnancies, she has already had 4 pregnancies, and we don't know what was her the last pregnancy and the present pregnancy, isn't it? That's what occurs within 6 months, because she'll be lactating also. The baby also already, the one baby also will be requiring a lot of nutrition from her. So again, she becomes pregnant. So that itself will produce more stress on her, the hemophytic system. That's how, she'll develop anemia again. So that is one of the factors which can produce. And another important history was that she had blood transfusion, packed cell transfusion during the previous pregnancy. That she has an history of developing anemia. Maybe most of the time it may be iron deficiency anemia, nutritional anemia. So that was there. So those are some of the positive findings, as I told you yesterday. So you make separate points of these positive things, so that as soon as you ask what are the positive findings in your history, just can read those positive findings in your history. Okay, so I think it is just 5 o'clock. So let us start today's discussion.
One doubt, sir.
Any doubt?
Sir, when you had told that the first time when she conceived, the time was important, sir, after marriage.
Time was important means, as soon as she is married and early, she has become a pregnant and repeated pregnancies. So that becomes very important, because she would not have got adjusted to her environment, a new environment. So that may be one of the social reasons that has been given as, the one of the factors for developing iron deficiency anemia or any kind of anemia, nutritional anemia as such. Okay, any other doubts regarding the previous discussions? Because your HOD had, we had a discussion today in the morning with your myself and your HOD, and I was complaining to him that your students are not asking any doubts. I was also appreciating you people that lot of improvement is there when I used to come as an examiner before, and now present students quite good as far as answering and all in our discussions. But I had one complaint regarding, not having many doubts and not asking about the doubts in anesthesia. It need not be whatever the present case discussion. It can be any doubt, so that, it makes you getting warmed for the discussion one. And also these doubts, whatever you have the doubts, the same doubts will be for many people. So that could be cleared. So that is another very important thing. So just to start with, people can interact with doubts. Okay, so let's start with the examination findings. So you just tell normal findings, you need not have to tell about the systemic examination, including probably the abdominal examination. If you just say normal this thing, only you can say that, it is IUGR is there. Like it is not expected for the 36 weeks. Like that, we can finish it off the examination fast, so that we can have more time for discussion, right?
Sir, only positive findings of examination could be told.
No, you start with general physical examination. So few things are important here. So those things you can always talk about.
Yes, sir.
So, yeah, you can just read that. And especially I read it. I'll just go through and systemic examination. If there are no positive findings, you can just say without any abnormal findings or within normal limits.
Yes, sir. Yes, sir.
Yes, just complete your examination.
Yes, sir. So general examination, patient is comfortable, conscious, oriented to time, place, and time. Person moderately built and well nourished. Patient height is around 160 centimeter, weight is around 52 kgs, and BMI of 20.3. With a pre-pregnancy weight of 45 kgs and weight gain of around 7 kgs in this pregnancy. Patient is paler with bilateral pitting edema of grade 2 extending up to 1/3 of the leg with no icterus, cyanosis, clubbing, lymphadenopathy, with skin paleness and nail contains vertical ridges. Vitals, pulse rate is around 96 per minute with regular rhythm, normal volume and character, no radial and radiofemoral delay. All peripheral pulses felt equally and bilaterally. Blood pressure is around 160 mmHg in the right upper limb in sitting position. And SpO2 is around 99% on room air. Respiratory rate is 16 per minute, which is regular, thoraco-abdominal type, and afebrile of temperature, 98.6 Fahrenheit. Airway
Within normal limits. Airway examination
normal.
is fine. Yeah.
Airway examination with the normal limits.
Okay.
Spine examination is also with the normal limits.
Okay.
Obstetric examination, patient is in supine position with thighs slightly flexed. Umbilicus is central and aorta, linea nigra and striatum gravida are present. No venous engorgement and no visible scars, sinuses, and dilated veins present. Palpation in legs in semiflexed position. Fundal height corresponds to 32 weeks and symphysis fundal height corresponds to 33 weeks, and abdominal growth is around 97 centimeters at the level of umbilicus and no local rise of temperature or tenderness present. Fundal grip, soft, broad, irregular, non-palatable nodular mass felt on the left side of the uterus, suggestive of a breach. And umbilical grip, firm, uniform resistance felt over the left side, suggestive of back of the fetus. Multiple nodules, suggestive of limbs on right side. First pelvic grip, hard, round, free, mobile, palatable mass, head to cephalic presentation. And in second pelvic grip, occiput is at lower level of sinciput, flexed head and not engaged. On auscultation, fetal heart sound present of 145 beats per minute, heard on the left side inferior to the umbilicus. Bowel sounds are systemic examination, CVS with
You can say if it is normal,
apical
not much of, except probably if there are any murmurs, you can always tell.
no CVS with the normal limits.
No, but you have written something regarding the murmur there.
It's an ejection systolic murmur. Grade 3/6 heard in the aortic areas. The respiratory system within normal limits. Central nervous system with the normal limits. So the summary, 24-year-old female with G4P3L2A1, gestation age of 36 weeks, hailing from low socio-economic background, complaints of easy fatigability, dyspnea on exertion, palpitation for the past 2 months, with history of irregular intake of iron and folic acid tablets, history of anemia requiring blood transfusion and lower birth weight baby in the previous pregnancy. And on examination, she is poorly nourished, has paler, vertical ridges in the nails with ejection systolic murmurs in the aortic area, with poor weight gain in the present pregnancy, and the size of the uterus does not correspond to the gestational age. And the third trimester USG scan shows fetal growth restriction.
Okay, so some of the things I just want to tell you some observations. So like you have written about the pallor. So you'll have to really, pallor 1 plus is normally present in all pregnant mothers. That we'll discuss now. I'll be asking you about physiological changes in pregnancy. But if you just write down pallor 1 plus, and finally, you cannot say pregnancy with anemia. Except in your history, you have written that some easy fatigability. Easy fatigability is very common in pregnancy, isn't it? That's what I was telling you. The NYHA class 1 to 2 is very common. So there is nothing in your history as well as your examination findings to say a patient has anemia with pregnancy. Physiological pregnancy is normal, isn't it? 1 plus is normal. So you should write down there what is the severity of anemia, that is a pallor, because you'll not get any investigation findings in the exam. So you'll have to show that it is more than normal physiological anemia, isn't it? So you'll have to write down at least pallor 2 plus or 3 plus. Then only you can come to the final diagnosis of saying that pregnancy with anemia. So that is one thing, one observation is always there. Of course, edema will be there in all pregnant mothers. So that is one thing. And second thing is body mass index is definitely very low for a pregnant woman, because there is no separate body mass index for pregnancies classification. But even then, usually about 23, 25 is nearly normal body mass index. But in her case, it is only 20 body mass index. So that is a positive finding to at the end if you want to tell. So that shows that in generalized, she has some nutritional intake problem is always there. That may be because of the hyperemesis gravidarum she had. Of course, airway is fine, spine is fine, obstetric examination is fine. So again, in CVS examination, you have written about there is a systolic ejection systolic murmur. So murmurs are very common in pregnant women, and especially in anemia with pregnancy, murmurs are very common. One thing is you should not just write down ejection systolic murmur grade 3/6. But usually you don't find ejection systolic murmur of grade 3/6 in anemia with pregnancy. Any systolic murmur of grade 3 and high up are abnormal or not a routine thing you can find out, even in anemia of pregnancy. Because even in anemia of pregnancy, what is this murmur due to?
Hyperdynamic circulation.
Pardon?
Hyperdynamic circulation.
Yeah, hyperdynamic circulation will be there in pregnancy. Probably more increase in the flow across the aortic valve. That will be the one which will be producing this kind of some amount of turbulence. But these are flow murmurs. They are soft murmurs. And because they are soft murmurs, the grading is usually 1 to 2. You can hear, probably in normal pregnancy, it may be just grade 1. In pregnancy with anemia, it can be grade 2. So it cannot be grade 3. So you should be careful in telling about that. And also you should, whenever you find a murmur, because I was telling you that all the symptoms of pregnancy as such, or pregnancy with anemia, will mimic mother having some cardiovascular disease. So when you have written a murmur, so unless you describe the murmur in detail, it is not that it is heard in aortic area, that's what it's fine. But, is there any radiation, whether it is better heard during inspiration or expiration, or any particular position and relationship with the murmur. So these becomes very important other than just grading. Because you have to rule out here, once you have written ejection systolic murmur, you have to rule out aortic stenosis, isn't it? In aortic stenosis also, you'll have a murmur in the aortic area, and it is an ejection systolic murmur. And the murmur can be anywhere from 3 to high up grading of murmur. But other things becomes very, very important in these. So those things also you should always try to write about. In detail, you should always describe. It is not just, a murmur heard in aortic area and no radiation, not enough. So you have to go into details. So that is what is there. Fine. And we'll go into the discussion part now. Okay. Just 1 minute. I'll close the door and come of the room. Okay. Sorry for that. Now, this patient has been admitted, isn't it? Why she has been admitted now? With mild anemia, with 1+ pallor, she would not have been admitted, isn't it? So what is the reason for her admission in 36th week only?
Because of her chief complaints, sir. She
Pardon?
had, because of her chief complaints, which she had complaints of easy fatigability and palpitation.
So for that, she should have more severe anemia, isn't it?
Yes.
She can't have one. That is what, you'll have to finally come to that. And then when you are discussing or when you are writing down or presenting, you should always be careful about that. Okay. Now, let us just discuss about what investigations you would like to do in this mother. And then we will discuss about physiological changes in anemia in pregnancy and how they have that anesthetic implications for us. And discuss about anesthesia for cesarean section for this lady. If she may not require cesarean section as such, but let us discuss, because already we have discussed about labor analgesia and also discussed about cesarean section in a patient with preeclampsia. Now we'll discuss about this lady going in for cesarean section. Okay, so what investigations you would like to do in this lady?
First, I would like to ask for the complete blood count, sir, where I'll be seeing the hemoglobin.
Okay, hemoglobin and hematocrit becomes important. So based on hemoglobin or hematocrit, how do you classify anemia in pregnancy?
Hemoglobin of less than from 10.9 to less than 4 is very severe. 4 to 7 is severe.
Don't start from the more severe. Start with mild, moderate.
Mild, moderate.
When do you say a mother to have anemia as such, when compared to non-pregnant state? Females. Non-pregnant, when do you say anemia based on hemoglobin?
Sorry, sir.
Hello? Hello?
Anemia. Yes, sir. Yes, sir.
There is some problem with your net.
For a non-pregnant,
Yes, sir.
non-pregnant, any hemoglobin level of less than 12 is considered as anemia, sir.
Okay. In pregnancy? In first trimester?
Pregnancy, it's less than 11.
No, first trimester, second trimester, third trimester.
Yes, sir. In first and third trimester, HB less than 11 grams is considered as anemia, sir.
Very good.
And in second trimester, less than 10.5.
Yeah, why in second trimester less than 10.5? Why in second trimester they say that less than 10.5?
Sir, because of hemodilution, there will be reduction in the RBC volume, sir. So that will lead to...
Because there won't be any further increase in the RBC volume, but plasma volume keeps on increasing in the second. So that is why, 11 grams, less than 11 in the first trimester, less than 10.5 in the second trimester, less than 11 again in the third trimester. So that is how you always. And based on the hemoglobin, you are trying to tell mild, moderate, and severe. So how do you grade?
Sir, we'll be classifying it as mild, moderate, severe, and very severe, sir. Mild is where the range is around 10 to 10.9, and moderate is around 7 to 9.9, and severe is around less than 4, less than 7, and very severe is less than 4, sir.
Yeah, very severe is less than 4, and it is not described in Western literature very severe, but it is very common in Indian or Asian population to have quite severe, because recently one of our students in JSS was telling that a woman was there brought as an emergency with cardiac failure with hemoglobin of 3 grams. So I think you also must have had such experiences. It's quite common. So that is there. So that is why hemoglobin becomes very important to classify. And again, why you want to classify this? Again, mild, moderate, and severe and very severe.
In order to transfuse, treat according to the gestation and severity of the patient, we'll be transfusing the patient, or we can go for parenteral or oral therapy, sir, for the patient.
Iron therapy, isn't it? So before that, you will have to make sure that it is iron deficiency anemia. So how do you make sure that it is iron deficiency anemia? Because there is no point in giving iron if there is no iron deficiency anemia, because there can be other nutritional deficiencies other than iron also. So how do you rule out, or how do you know it is iron deficiency anemia as such?
Sir, I will go ahead and ask for investigations.
What investigations?
Of serum iron, serum ferritin, total iron binding capacity.
Very good.
And,
transferrin saturation, sir.
Yes, very good. So what is the normal ferritin levels? What is ferritin actually?
Ferritin, which binds the iron to the
storage form of iron.
Storage form of iron.
Yeah, intracellularly, it is always the ferritin only. Iron will be available in the intracellular compartment as ferritin. That is why you must have seen that ferritin levels also increase in inflammatory conditions. Especially recently, we had the COVID-19. In that, there used to be, it was an inflammatory marker, because cellular death, and then majority of this ferritin would be there in the blood, and serum ferritin would increase. So that you have to rule out in case of whether it is inflammatory process which has increased ferritin, or it's because of iron deficiency anemia. So ferritin levels are normally, it's very important to just check to rule out iron deficiency anemia. I was asking you what are the normal ferritin levels. Normal ferritin levels will be more than 50 nanogram per ml or 50 micrograms per liter. So because, it is not just getting an investigation done, you will have to know how to interpret also. So if you know normal, then you can know abnormal. So when do we say iron deficiency anemia based on ferritin levels is if it is less than 30 nanograms per ml or 30 micrograms per liter. Then we say it is iron deficiency anemia based on only ferritin levels. But ferritin can be increased in iron deficiency anemia with inflammatory process. Then you cannot say whether it is still the mother has iron deficiency anemia or not. Suppose if she also has some chronic inflammatory process or an acute inflammatory process. So other investigations like you were telling about serum iron and total iron binding capacity, and why the serum iron and total iron binding capacity is important to we should know.
In iron deficiency anemia, the total iron binding capacity will be more, sir, whereas other components will be reduced. So which itself is suggestive of iron deficiency anemia, sir.
No, what happens to the serum iron?
It will be reduced, sir.
Serum iron will be reduced, but it can be normal or increased, isn't it? So what is this transferrin percentage? What is transferrin? Transferrin is the principal protein which carries transports iron. So transferrin saturation percentage becomes very important. So how do you calculate transferrin saturation percentage? It is serum iron divided by total iron binding capacity. That's why you people were telling that I was thinking that you are going to tell about transferrin saturation percentage. So that is what is transferrin saturation percentage is serum iron. You know that you can measure serum iron, and divided by, you also can measure what is the total iron binding capacity. So the ratio is transferrin multiplied by 100 you get the transferrin saturation percentage. So when do you say a patient has iron deficiency anemia based on transferrin saturation? Because this is very important whenever there is an acute inflammatory process where ferritin levels may be on the higher side. If it is less than 20%, normally it will be higher, maybe 50 to 60% it will be there. But when you have this transferrin saturation percentage less than 20%, you say the patient has iron deficiency anemia. Okay. So again, the other investigations, like you are talking about complete blood count. So whenever you have the hemoglobin or hematocrit, they also will give you what is the mean corpuscular volume and mean corpuscular hemoglobin concentration also. Why these two are important in iron deficiency anemia? What happens to MCV?
Because the MCV, MCH, and MCHC all will be reduced in iron deficiency anemia, sir.
Okay, so suppose if patient has both, when MCV can increase?
In macrocytic anemia, sir.
Yeah,
It will increase to more than 90, sir, 90 femtometers.
Okay, so suppose this patient has both iron deficiency anemia and B12 folic acid deficiency. She can have, isn't it? Because she has nutritional problems. So in that, what happens to the MCV? Is it
MCV will be
increased or is it decreased?
Increase MCV.
No, increased only if B12 deficiency is there.
B12 deficiency. Yes.
Oh, she has both iron deficiency and B12. In iron deficiency, it should decrease, microcytic, isn't it? Whereas in B12, it is macrocytic. That is what we always say, macrocytic, microcytic, hypochromic anemias. So what happens to the size? Suppose the size is normal, but patient has decreased hemoglobin, decreased hematocrit, she has anemia. What could be the cause? If it is nutritional deficiency, I'm talking about. It can be, in both
Iron deficiency also.
and B12 deficiency, it will be normal. Size will be normal, but it will be hypochromic. Size also can be normal in other hemolytic, some of the hemolytic anemias like thrombocytopenic purpura, especially thrombotic, idiopathic thrombocytopenic purpura also. There is more hemolysis, and the size of the the RBC may be normal, and even it can be normocytic also there. So that's how you differentiate whether it is microcytic hypochromic, macrocytic hypochromic, normocytic hypochromic. So it can also, all these can be there. So that is why you get all these things when you ask for total blood count, isn't it, or a complete blood count. So these things are important for you for exams also. So just remember about this. Okay, so what other investigations you would like to get before we go into the discussion part?
Want to get a renal function test, urea and creatinine to rule out anemia of chronic disease, sir.
Yeah, chronic renal failure is one of the causes. Okay, right.
I would like to get a liver function test to know the albumin values. So albumin values can be reduced in anemia, sir.
Normally it is reduced, isn't it?
Normally
But it can be reduced more actually because she has so much of fetal edema and including extending up to the knee joints. That is what you had discussed, right? Before that, platelet count.
Platelet count, yes, sir.
Because I just now told you ITP, TTP. So there can be destruction of the platelets, also can produce normocytic, normochromic anemias. So that is why platelet count becomes very important. She may be bleeding also, isn't it? Okay, okay. Then
I would like to get a blood grouping, cross matching, and serology transfusion, sir.
yeah, grouping and cross matching, because if she happens to be having severe anemia, you may require to transfuse her, like she had a transfusion before, isn't it? Okay. Now, at this juncture, I just want to ask you, suppose she has 5 grams hemoglobin. Would you like to transfuse her with packed cells, or would you like to still give iron? because she's already crossed 36 weeks.
If the patient is more than 36 weeks, sir, so I would like to go for transfusion, sir, because whenever we give iron therapy, it takes 4 weeks to replenish in the blood volume. So it's better to go with the transfusion if more than 36 weeks of gestation, and we have to see for the severity of the symptoms also, sir.
So, but parenteral iron will increase in 2 weeks.
2 weeks. Yes.
So you can still go for parenteral iron if it is just 36 weeks. But because, one thing you should realize, blood transfusion sometimes produces uterine contractions. Many of the women will go into labor. So that is one thing you should always keep in mind. So unnecessary transfusion should be avoided as such, because still 4 weeks are there for her, delivery, 40 weeks. And still iron therapy, parenteral iron therapy you can still give. But suppose if you give transfusion of packed cells, so 1 unit of packed cells will increase the hemoglobin by how much in this lady's case? She's 60 kgs, you said. 50 kg or 60 kg she is?
52, sir. 52 kgs.
50, let us say 50 kgs. How much increase of hemoglobin occur? Because that is what finally you'll have a target. Okay, let me have a target of 8 grams of hemoglobin for her before taking up for cesarean section. And you should know how many packed cells you may have to transfuse her before getting that or to reach 8 grams of hemoglobin. One unit of packed cells will increase by how much? No, you should know, isn't it? Because otherwise, how do you know how many units of packed cells you have to give? So let us, discuss about this. 1 unit of packed cells is how many ml?
Around 250 to 300 ml.
No, it is standard. How much is? Like platelets, we were telling that 50 ml is RDP, 250 ml is STP. These are all standard. So like that, 1 unit of packed cells means how many ml it will have? So it will have 300 ml. It is always standard in all the blood banks. 300 ml. Okay, if it is 300 ml of packed cells, so what will be the hematocrit of these packed cells? Or how much of hemoglobin or hematocrit this 300 ml will have? Hello, I have lost you, I think.
Sorry,
Yes,
sir.
Sorry, sir.
Your net problem again.
Yes, sir. Yes, sir.
Okay. Now, how much of hematocrit these packed cells will have? 300 ml you are supposed to transfuse. Once you know about this, you know how much increase will occur. What is the hematocrit of these packed cells? Because they are not only packed cells, along with that, saline also will be there. Otherwise, only packed cells, it is solid, you cannot transfuse. So it is diluted with saline. And also anticoagulants will be there. So all these things will be there. So the hematocrit is 60%. 60% means 60% with percent, 100 ml, isn't it? So if it is 60%, how many grams of hemoglobin it will have? How do you convert hematocrit to hemoglobin? These are the basic things you are supposed to know, isn't it?
3 times
Yes.
hemoglobin with the sir.
How do you convert hematocrit to hemoglobin?
3 times the values of hemoglobin.
Pardon?
3
3 times the value of
Yeah.
hemoglobin will be the
Hematocrit divided by 3, you get the
3.
hemoglobin, isn't it?
Yes.
Now, how many grams of hemoglobin this 300 ml will have?
1 gram, 1 to 1.5 gram.
No. See, 60% is the hematocrit. divided by 3 is 20 grams. 20 grams in 100 ml.
Yes, sir. 20,
Yeah.
60 grams.
So 60 grams will be there in this.
Yes.
So that means if you are transfusing 1 unit, you are adding how many grams of hemoglobin to her?
60 grams of
60 grams of hemoglobin you are adding.
you're adding it. Yes.
So, you know, let us say her, this thing is roughly about 50 kgs. Usually by 36 weeks, the total blood volume will be roughly 90 ml per kg body weight. Whereas in non-pregnant states, 70 ml per kg body weight for males and 65 ml per kg body weight for females. So it is nearly 90 ml. So 90 multiplied by 50 is 4,500. That is her blood volume. So you are adding this 300 ml into 4,500 ml of blood volume. So total, let us say it is about 5 liters now. Isn't it?
Yes.
So in 5 liters, how much of increase of this thing has occurred? How many grams of hemoglobin you've added? 60 grams.
60 grams.
In 5 liters, you have added 60 grams. But hemoglobin, we always measure per 100 ml. So in 100 ml, how much increase has occurred? So 100 multiplied by, 60 divided by 5,000. Roughly, it is 1.2 grams. Now you understood how you should calculate.
Yes. Yes.
That is why we always say, usually, 1 unit of blood transfusion usually may increase the hemoglobin level by 1 gram. So, but it need not be 1 gram. It can be even higher or it can be lower depending on the blood volume. That is why you should know how to calculate. So this is one thing many of the examiners will ask you if you have a pregnancy with anemia. So you should know how to calculate how much each unit of, because then, suppose I was telling you that she has 5 grams of hemoglobin. Now you'll have to bring it to 8 grams. So how many packed cells she requires now?
3 units of
At least about 3 units of packed cells. Then only, because many of the time the obstetricians will ask you, so how many packed cells should I give? Because, for obstetricians, it is always, you are the physician many times. For all surgeons, anesthesiologists are because you are going to give anesthesia for her. So you have to know. So that is why this particular calculation, you should always know how to do. Okay. So that is one thing you should always know about. Now, these investigations you have done, and suppose you want to give iron therapy also, I was telling you that you can definitely give. What is the requirement of iron in pregnancy as such?
1 gram, sir. Throughout the pregnancy, it's 1 gram. In the first trimester, it's around 2.5 grams. And in the second trimester, it's around 4 to 5 grams, sir. And in third trimester, it's around 8 to 10 grams.
Per day.
Yes,
That is elemental iron. But when you want to give iron, usually how much they require? Suppose you are giving tablets of iron, because many times you will be giving ferrous sulfate tablets, isn't it?
Yes.
So how much? Each tablet contains how much of iron actually?
60 milligrams of elemental iron will be present, whereas the absorption will be around only 10% of the elemental iron, sir. So around 6 mg will be available to the patients.
Yeah, but usually the dose is how many milligrams of iron you will be giving per day from the second trimester onwards? Usually they require about 30 milligrams of iron. And sometimes, if they have some gastric disturbance and all, you can give alternate days 60 milligrams. But this you can give till probably 30 weeks of pregnancy. But you after 30 weeks of pregnancy, if you find that they have iron deficiency anemia, it is always better to go for parenteral iron, isn't it? So that you must be knowing how to calculate the total iron requirement when you want to give IV therapy of iron. So how much iron required? How do you calculate?
Sir,
2.23 into 2.23 into body weight into 50 minus hemoglobin.
hemoglobin plus anything reserve to increase the reserve plus 1000 milligrams.
Plus 1000. Okay.
It is always there because you have to increase the reserve. These patients, when they have already deficiency, they don't have any reserve. So the reserve also has to be increased. The reserve is usually 1000 milligrams. So that is why either 2.3 or you can even say 3. 3 multiplied by what is the, you cannot take 15. 15 you don't want to increase, isn't it? So as long as it is about 12, it is fine. So you can even say it can be about 12 or 13 minus whatever the patient's hemoglobin levels and multiplied by body weight and plus, the 1000 milligrams as the additional reserve. So you calculate and then what kind of iron usually is given?
IV iron sucrose, most commonly given.
Iron?
Iron sucrose.
Yeah, iron dextrose or iron dextran many times is given with low molecular weight iron. So that is how you give. So do you take any precautions when you are giving?
Give a
What
test dose.
complications do you expect? Yeah, test dosing.
We give a test dose for dextrin particularly, sir.
Yeah, how much of test dose? Because you're giving as an infusion, isn't it?
Yes.
You're going to add this into 100 ml or 500 ml of saline, and then you are going to infuse. So how much of test dose first IV and then observe her for about 10-15 minutes and then followed by the remaining part.
Sir, in iron sucrose, it will be available in 50 mg per ml, sir. It will be available as 1 ml or 2 ml solution. So first we will, as a test dose, we will put 25 mg in 100 ml NS and we will give it over 15 minutes and see for any anaphylactic reaction, and we will also monitor for the hemodynamic status of the patient and respiratory rate and everything. And then we will go ahead, if there is no reaction, we will go ahead with 250 ml of NS plus remaining 150 mg, 75 mg of iron sucrose in the solution, and we'll give it over 30 minutes. Sir.
Yeah. Can you give total dose in a day? Whatever the calculated total dose?
Yes, sir. If there is, you can give it as a single IV push also, sir.
Yeah, that also you can give, provided, you have to be very careful because the volume, total volume also you have to be very careful because these patients already having hypervolemia will be there. Because of one is pregnancy, second thing is because of anemia, hyperdynamic circulation, they may go in for failure. High output failure is quite common in the severe anemia patients, isn't it? So that you have to be careful about, but you can still give that. That is going to increase your hemoglobin level or hematocrit in just 2 weeks. That is an advantage. That is why, after 30 weeks, you always go for IV parenteral iron. You can also give even intramuscular also, but better not to go for intramuscular because it is irritant, it is quite painful. You have to
staining of the skin and abscess formation is also more.
So in order to prevent staining of the skin, you have to follow a certain procedure. What is the procedure?
Z-track technique.
Yeah. So that technique you have to follow. So these are some of the things about the iron therapy. Okay. So just, enumerate all the physiological changes in pregnancy and how they are going to implicate the anesthesia part. One by one, systemic examination, system-wise, involvement of physiological changes. Why physiological changes in pregnancy as such they occur? Why they should have these changes?
First thing, fetus requirement of the fetus is more nutrition for the nutritional supplement and oxygen supplementation, and for the blood supply to the fetus, uterus, and placenta. And then, in order to compensate the stress during the labor and pregnancy, these physiological changes happens in the pregnancy.
One thing you can always say that whatever the physiological changes that occur are all for benefit of the fetus, which is a parasite there, isn't it? It totally depends on the mother. So whatever, everything, it starts with a minute, microscopic cell, zygote, and then it grows to about, 2.5 to 3 kgs. So for that, all these things will be required. Plus, there is going to be a uterus also is going to increase. Uterine blood flow also increases. What is the normal pre-pregnant uterine blood flow, and with pregnancy full term, how much increase in uterine blood flow occurs?
250 ml per minute.
Normal pre-pregnant uterine blood flow to the uterus. Usually around 60 to 70 ml per minute. But with full-term pregnancy, it can go up to 700 to 800 ml per minute. So because, it would have grown so much, the uterus also, to supply enough of nutrition to the fetus, growing fetus. So that's why many of the physiological changes in pregnancy occur for the benefit of the fetus. So let us discuss about each system-wise. So you can start with the respiratory system, and it's simply because, respiratory system is so important for us as anesthesiologists, and its changes and implications for anesthesia. So you please go ahead.
Starting with respiratory system, we'll start with the upper airway, sir. Upper airway.
Your voice is not very clear, Shruti and Hema. Even Dr. Parthasarthi sir also has commented. Sir, good evening. So he has commented that you people voice is not very clear. Maybe the problem with the net there. So anyway, yeah, please tell. Let us not waste much time.
Starting with the respiratory system, starting with the upper airway, sir. In upper airway, there's an increased edema to the in the front of neck, in the back of neck, and in the buccal mucosa, tongue, and also in the face. So because of which there will be we'll require a bigger size masks for ventilation. That's first thing. Second one is because of the increased accumulation of fat in the back of neck, it will be difficult to extend the neck, sir. So because of which the mask ventilation will become difficult, we'll have to use a jaw thrust maneuver to mask ventilate the patient, sir.
Because these things we did discuss when we discussed about preeclampsia.
Yes,
in detail, because all these changes would be exaggerated in preeclamptic mothers.
Yes.
But anyway, all airways of upper airway of pregnant mother is considered as a difficult airway. That is one thing. As you said that there is more accumulation of fluid, back of the neck, front of the neck, and in the tongue, inside the tongue, inside the oral cavity. So all this will increase the chances of difficult mask ventilation. Already we have discussed. And again, Mallampati scoring will be
increased. Yes, sir.
Size of the tongue will be there. So.
Yeah, because size of the tongue increases, the volume of the buccal cavity will decrease.
Yes.
So the oral cavity will decrease. So that's how the grading of Mallampati is increasing. So that is another reason. And this what happens immediately after the delivery of the fetus.
After delivery, because of auto transfusion, there will be there'll be more edema, there'll be more fluid accumulation in the buccal mucosa and tongue. So because of which the intubation will become more difficult, sir.
Yeah. So whatever you suppose, if you have examined the mother before the delivery of the fetus, when she is in labor, and immediately after delivery, for example, many times these mothers may come for retained placenta extraction.
Yes.
So you may have to give anesthesia. You might have examined her before, but after delivery, the Mallampati classification can be more, higher grade. So that is why you have to re-examine. That is the importance of knowing about this. So, somebody has taken photographs and then presented also regarding the pre-pregnant Mallampati and then pre-delivery Mallampati and immediate post-delivery Mallampati classification. So can you just read who has done this? Because he is an Indian, so that is how just asking you. You must have heard about Dr. Bhavani Shankar Kodali. Have you heard about Dr. Bhavani Shankar Kodali? No, you must have heard about capnography.com.
Yes, sir. Yes, sir.
Yes. He has done a lot of work on capnography. So he had presented a paper. Actually, he had taken photographs, serial photographs of many women before when they are in labor, but before delivery and after delivery. So you can see Malampatti, which was class 2, has gone for class 4. So because he is an Indian and settled in US, so their Indian contributions should always remember. Like Malampatti himself, isn't it? Last time I was asking what is the full name of
Sheshagiri Mal.
Yeah, Sheshgiri Rao.
Rao.
Rao S. Malampatti.
Yes.
So you should always remember.
Yes.
Okay. So difficult mask ventilation, you have just said, because Malampatti scoring is also on the higher grade. So difficulty in laryngoscopy and intubation also.
Yes.
Isn't it? So another thing is enlarged breasts. So they'll come in the way for you. So you may have to go in for
a video laryngoscopy, sir.
Yeah, one is either video laryngoscopy or a short handle.
Or you use a fibro.
No, short handle.
Fibro. Short handle blade, polio blade, sir.
Because one thing I was telling about patients with preeclampsia. There it is, all these are more exaggerated. It is no point in going in for a regular Macintosh, laryngoscope. There it is better straight away you go for a video laryngoscope. But whereas, pregnancy without much of preeclampsia or any other such cardiac problems are not there. So you can still go for your Macintosh blade, but only thing is you have to go for either a short handle laryngoscope or any other laryngoscope you would like to go for. Not video laryngoscope. I'm just asking. Something where there is an obtuse angle laryngoscope.
Yes, sir.
What is angle laryngoscope? What you call that blade as?
Polio blade, sir.
Yeah, polio blade.
Polio blade.
So you can even go for having, if
polio
you
blade.
have a blade, definitely you can go for that also in these mothers. And another thing is, how do you make sure that, the breast will not come in the way?
So we can insert the blade first, sir. Once the blade is gone inside, then we can attach the handle, sir, so that the breast don't come in the way.
No, otherwise the positioning itself of the mother.
Semi-recommend position.
Pardon?
Semi-recommend position.
No, that is one thing. And plus, once you abduct the hand, the upper limbs by 90 degrees, automatically the breast will fall onto the sides. So they may not come in the way. So that is another thing. Plus slight 15-degree upper torso elevation. Also, these two things you can always make sure. And in one of the books, it was also given. So like when a person who is going to give the tricard pressure, because that is another very important thing. So he can place his hand over the chest like this. So, and then place and put his fingers there. So once he is putting his total hand over the chest and then trying to give the tricard pressure. So he is going to prevent the breasts also coming in your way of introducing the laryngoscope.
Yes.
So these are some of the changes which you have to make.
Yes.
Okay, then, right. So difficult laryngoscopy, difficult intubation. Then in supraglottic device.
We'll have to go for a small, because of the space will be less. So we'll have to go for a smaller size supraglottic airway device.
So that is, there can be a difficulty in positioning the supraglottic airway.
Yes.
And one more problem is surgical airway.
Yes, sir. Because of the short neck, sir. They'll have a short neck, so it will be difficult. The sternomental distance will be reduced, sir. So once it's reduced to less than 12 centimeters, we can expect an anteriorly placed larynx, and also the landmark for the surgical airway will be difficult, sir.
And that is mainly because of the accumulation of fluid and fat in front of the neck.
Yes.
So landmarks, as such in females, it is very difficult to identify. So here it become more difficult. So either you mark the cricothyroid ligament, or what else? How do you identify in an emergency? What is laryngeal handshake? Must have heard about laryngeal handshake. So that is how, you just, palpate first the hyoid bone. Hyoid bone, you easily can palpate. Anybody.
Yes.
So with your index finger and your middle finger, you palpate, shake you can just shake it. Now you are 100% sure that you are palpating the hyoid bone. And with your the index finger, kept in the midline. Keep coming down. Now, after that, you will have the thyroid cartilage, you can easily feel. And again, keep feeling in the midline. And then immediately as you come down below the thyroid cartilage, you get a depression. And that is the cricothyroid ligament area. So that you can keep it there, and then you can proceed with whatever, either cricothyroidotomy or whatever you want to do to get the front of neck axis. You may have to do that. So that is what is called as laryngeal handshake.
Handshake.
Not heard about this laryngeal handshake?
No, sir.
So just you may be asked. So just remember about this. Okay. So those are because there can be laryngeal edema also, edema of the glottic area. So how that it imply for you?
We'll have to go for a smaller size endotracheal tube, sir.
So what size you will be taking?
6 or 6.5.
Usually 6.5, whereas if preeclampsia, then 6.
6, yes.
So otherwise 6.5 to 7 is fine. Okay. So lower respiratory tract.
In lower respiratory tract, the diaphragm will be pushed up because of the gravid uterus, sir. So because of which, but the downward displacement of the diaphragm will be normal. So there'll be an increase in the tidal volume, sir, by 30% in the first trimester and 40% in the third trimester, sir.
Okay. So
And
increase tidal volume.
Tidal volume. Increase in respiratory rate by 15% will be there, sir.
Okay.
Because of which the minute ventilation also increases by 50%.
Yeah. Alveolar ventilation and minute ventilation will increase by 50%.
50%.
Right.
The expiratory reserve volume and
Residual volume.
residual volume will reduce by 10% each, sir. So adding both, the functional residual capacity will reduce by 20%, sir.
Yeah, so there is a decrease in functional residual capacity by 20%, but increase in alveolar ventilation by 50%.
By 50%.
Right.
Yes.
Then.
So because of this, their IV induction.
No, we will go into. I'll ask you.
Yes.
So you just tell all the changes in the lower
sir.
respiratory system. So what happens to the vital capacity?
No, normal or
Normal.
Normal.
Yeah, what happens to the inspiratory capacity?
It will be normal, sir.
Inspiratory capacity will be slightly increased because both inspiratory reserve volume will increase and tidal volume will increase. Already you have told that tidal volume will increase by 40%. Inspiratory reserve volume will increase by 5%. So, you know, your vital capacity is inspiratory reserve volume, tidal volume, and expiratory reserve volume. Because expiratory reserve volume is decreased, but it is compensated by increase in the tidal volume and inspiratory reserve volume. The reason vital capacity will not change. But inspiratory capacity will increase. Inspiratory capacity is a combination of inspiratory reserve volume and the tidal
volume. Sir, there is an interruption, sir.
So suddenly we keep losing you.
Yes,
net is...
Sorry, sir. Sorry, sir. There is an...
No, you need not tell sorry for me. You can't do anything because all technical problems. So you cannot help it. Anyway, so there is vital capacity. How inspiratory reserve volume and the tidal volume will increase actually? What happens to the chest measurements?
It will all be increased.
Anterior posterior diameter will be increased due to...
And transverse diameter also increase.
Also will be increased.
Yeah, why they'll increase?
Because the diaphragm gets pushed up, sir. So
no, diaphragm gets pushed up, the anterior posterior and transverse diameter, why they should increase? The diameter will decrease.
The rib cage will be expanding.
How rib cage will be expanding more? What happens to the ligaments? That is what?
Ligaments will be, yes, sir. It will all be lax, sir.
So that you should always tell.
Yes.
So costochondral ligaments are lax so that, you know, you can stretch more. That is why anterior posterior and transverse diameter will increase. So that's how inspiratory reserve volume and tidal volume will increase and vital capacity will be maintained.
Yes.
Okay. So these are some of the changes. Plus, what happens to the PaO2, the gases?
Yes, sir. PaO2
will
be
increased, sir. PaO2 will be increased because of respiratory rate is also increased. And
So just tell what happens to the PaO2. PaO2 means partial pressure of arterial.
arterial oxygen, it will be increased, sir.
What is normal PaO2 in non-pregnant states, and what happens in
Sir,
pregnancy?
in non-pregnant, it will be around 90 to 95, sir. Whereas in pregnant ladies, it will be 100 to 106 mmHg, sir.
It can be increased to 103 to 105. So millimeters of mercury. What happens to the PaCO2?
It will be reduced, sir. In non-pregnant, it will be around 38, whereas in pregnant ladies, it will be around 32, 30 to 32.
Yeah. 30 to 32 PaCO2. What happens to the pH?
It will be slightly in acid, alkalosis.
Increases, sir. So alkalosis will happen.
Slightly moderate. Because what happens to the bicarbonate levels? Because the PaCO2 is decreasing. Bicarb also to maintain pH. So what will be the bicarb level?
Reduces, sir. It will come to around 20, sir, at the time of the
20 to 22, sir.
The kidneys will start increasing the excretion of bicarbonate in order to make good the respiratory alkalosis. The mother will be having increased respiratory rate and tidal volume. So, okay, now these are some of the changes. Let us discuss about the anesthetic implications. You are talking about FRC being low and alveolar ventilation is high. So, what are the implications? FRC being low, first of all.
The inhalational induction will be faster because of this.
Inhalation induction can be faster. Okay. Okay. What about pre-oxygenation?
Yes, sir. Because the FRC is low, we'll have to adequately pre-oxygenate the patient before. It will be faster.
Time for denitrogenation.
Faster pre-oxygenation.
Faster, isn't it? Because the time constant for denitrogenation will be short.
Yes.
Because FRC is small and the alveolar ventilation is high. So definitely, but still you want to pre-oxygenate them for a shorter period or regular period?
Adequately pre-oxygenate the patient, sir.
Why? No, adequately is fine. Even if you pre-oxygenate for even 1.5 minutes, their FRC will be filled because alveolar ventilation is so high and denitrogenation can occur in just 1.5 to 2 minutes. You need not have to go for 3 minutes. But what else is also there? There is one more life is there.
Yes,
so you'll have to adequately increase the PaO2 of the fetus also.
Yes, sir.
Isn't it? So in order to increase the PaO2 of the fetus, so you have to slightly prolong your pre-oxygenation time.
Yes.
So you may have to go for regular pre-oxygenation of 3 to 5 minutes.
3 to 5 minutes.
That is one thing. And second thing is because there is decrease in FRC, they are prone for what? What happens to the oxygen reserve?
Oxygen reserve reduces, sir.
Reduces. Because FRC is reduced, what happens to the closing capacity?
Increases.
Closing capacity
it relatively increases. Whenever FRC decreases, always CC relatively increase. It will not change as such, but it may increase. So naturally, the reserve, it's always FRC, whatever the oxygen that is there in the FRC is always the reserve, isn't it? So the reserve is decreased. So because the reserve is decreased, what is the problem?
Apnea will take place so soon, sir. More prone for apnea.
No.
Apnea during the period of apnea, the PaO2 will reduce further, sir, in pregnant women.
You have to say rapid desaturation during 1 minute of apnea. Yes. Why we call it as 1 minute of apnea? Why are you bothered about? Why 1 minute of apnea will produce rapid desaturation?
Because it will reduce the PaO2.
No, that is there. Desaturation will occur. Yes. Why this 1 minute you keep telling about? Why not 2 minutes? Why not 3 minutes?
Sir, in ODC curve, that the plateau phase.
No, I'm talking about 1 minute apnea. I'll give you a clue. Okay, you want to go for rapid sequence induction.
Yes, sir.
So, how long the mother can be apneic during rapid sequence induction? When you don't ventilate?
After
giving succinylcholine.
After giving succinylcholine, we don't ventilate.
But mother is paralyzed, apneic. How long you will be allowing this apnea to continue before you start your laryngoscopy and intubation?
Maximum of about 1 minute, sir, not more than that.
See,
45
that is the time they
45
decide.
seconds.
Yes.
Now you understand why
Yes.
I was stressing
1 minute.
1 minute of apnea.
Yes.
Because invariably you will allow her to become apneic for 1 minute. Of course, now we are doing a para-oxygenation also, that is different. But since the age-old method of managing rapid sequence induction is 1 minute of apnea for succinyl choline to act.
Yes.
It takes 60 seconds, and immediately after 60 seconds, you do a laryngoscopy and start, intubating the mother. So 1 minute of apnea is very common.
Yes.
So in non-pregnant states, 1 minute of apnea will produce a desaturation, how much of decrease in PaO2? And in pregnancy,
In non-pregnant, about 115 mmHg of fall in PO2, sir.
non-pregnant.
Non-pregnant, sir.
No. Hema?
Sir, 80, so PO2 of 80.
No. So in non-pregnant states, they have found out, many studies have been done. They have found out fall is about 58 millimeters of mercury. Provided you already, because, pre-oxygenation, you would have given 100% oxygen. Yes. Whereas in case of pregnancy, the fall is up to 137 millimeters of mercury. So that means it is almost 3 times fall occurs. So that is the importance of, denitrogenating properly these mothers. And also, it's a difficult airway. So the apnea can be extended. It need not be within 1 minute, you are going to get into the airway. It may even take sometimes, because you always expect a difficult airway, the apneic period may get extended. So for that, it is para-oxygenation is very important. That's how, 15 liters of oxygen, nasal oxygen, you continue to give. One thing. Second thing is you may have to go for, ventilating the mothers. Like with yesterday we were discussing, with low airway pressures of around 15 centimeters, not to increase more than 20 centimeters. So that also it's modified rapid sequence induction you go for. Or you can even use Thrive or high flow nasal oxygen also.
Yes.
Now, Thrive and high flow nasal oxygen also supposed to increase the, also can to CPAP. Some amount of CPAP also will be there. That means the FRC is increased and closing capacity will be decreased. So that way reserve will be increased. So these are all the implications of this increased ventilation and decreased FRC. Okay, and if you want to go for inhalation induction, they can definitely rapidly they can get induced. That is another. So why should you worry about this rapid induction with inhalation anesthetic agents? Because usually, what are the inhalation anesthetic agents you use for inhalation induction?
Sevoflurane.
Sevoflurane
Is the
and
Desflurane.
any other inhalation anesthetic agent you could use, which may be obsolete now. Many of the places you may not have, but it was routinely we were using that. Halothane, isn't it?
Halothane.
Now you'll be more worried about halothane and also sevoflurane, because 1 Mac of sevoflurane may not produce much of cardiovascular problems, isn't it? But when they rapidly get induced, the MAC value may increase beyond 1. It may go into 1.5 to 2. That can produce decrease in cardiac output also by myocardial depression. Whereas with halothane, a sudden increase in the MAC value or high concentration of halothane can severely depress the myocardium. And we know that halothane sensitizes the myocardium also. There can be even dysrhythmia and arrests have occurred, cardiac, severe bradycardia, arrest, especially junctional bradycardia. So that is why, this particular thing about increase in alveolar ventilation and decrease in FRC, you should know. And why there is increase in PaO2. Reason for increase in PaO2 in these mothers. You said 103 to 105. How 103 to 105 can occur? What happens to the alveolar partial pressure of oxygen?
It increases by 40%.
No, why alveolar partial pressure of oxygen will increase? How it increases? How do you calculate the alveolar partial pressure of oxygen? What equation you use for calculating? use alveolar air equation or alveolar gas equation. What is this alveolar air equation?
Yes.
What is this? Can you just tell the equation or the formula?
Vapor into atmospheric minus vapor into FiO2.
Forgotten probably. It is, atmospheric pressure, the PB minus pH2O, the water vapor pressure. That is usually, 47 millimeters of mercury. Atmospheric pressure is 760 millimeters of mercury. So that comes to 713 millimeters of mercury multiplied by the FiO2. So FiO2 is usually the 0.21 FiO2 because air contains 0.21 FiO2, isn't it? So this will be the PiO2. This you have to deduct carbon dioxide because in the alveoli carbon dioxide also will be there, isn't it? And respiratory quotient is roughly 0.8. That is, the carbon dioxide that is produced divided by oxygen consumed, isn't it? So now the PaCO2 is in the numerator, minus PaCO2 divided by respiratory quotient. Normally PaCO2 is 40, respiratory quotient is 0.8. So then from the PiO2, you will have to deduct 50 millimeters of mercury. 40 divided by 0.8 will be 50. Now in these mothers, what will be the PaCO2?
32 will be reduced, sir.
32?
30.
Let us say 30. So what is 32 divided by 0.8? It's 40.
40.
Isn't it? So instead of
Yes.
deducting 50 normally, now here you will be deducting only 40. So that you get is the partial pressure of alveolar oxygen. So partial pressure of alveolar oxygen itself will increase. And A gradient, alveolar to arterial partial pressure of oxygen gradient also will decrease. Normally it is 5 to 25 millimeters of mercury, the gradient. So here it will further decrease so that, whatever that is there in the alveoli will be there in the blood. That is a partial pressure of arterial oxygen because the increase in blood flow is there. Diffusing capacity across the alveoli will increase. So that's how the PaO2, partial pressure of arterial oxygen, will increase. So these are some of the basic things they'll ask you. So you should know about these things. Why is an increase in PaO2? That is again because of the increase in partial pressure of alveolar oxygen. That is because of the decrease in the PaCO2. And PaCO2 will decrease because the dead space is decreased.
Yes.
Because increase in blood flow across the lung. Once the increase in blood supply to the lung increases, so the dead space
Yes.
decreases, isn't it? There will be more zone 2 rather than zone 1. So that's how the PaCO2 will come down. Plus there is increase in alveolar ventilation. They are throwing out more carbon dioxide also. That also will decrease carbon dioxide levels. So these are things why there is a change in the blood gases. So that you should always realize about. And what happens to the oxyhemoglobin dissociation curve?
Sir, the ODC curve will be shifted to the right
In pregnancy.
In
Yes, sir.
pregnancy.
And also in anemia, it will be shifted further, isn't it? So this
Yes, sir.
also you should understand. So again, what is this? Is it related to pH? It is changed, or it's because of the increase in 2,3 dB?
Increase in 2,3 dpg, sir. As a compensation
Because
to
mainly there is an
anemia.
increase in 2,3 dpg, isn't
Yes.
it? So
Yes.
yeah, that is there. Physiological anemia is there. The 2,3 dpg levels will increase in pregnancy. So OD curve is always shifted to the right, so that oxygen release tissues can be better. And there is something called as a double bore effect at the level of the syncytial tropoblast of the
Yes.
placenta. What is this double bore effect?
In the mother, the ODC curve is shifted to the right, sir. So there will be more oxygen released from the hemoglobin, sir. In fetus, there will be the ODC curve will be shifted to the left. So there will be an increased affinity of oxygen to
fetal side. ODC shifted to the left.
Because of increased consumption of oxygen, more affinity of oxygen to the.
No, why there is the curve is shifted to the left on the fetal?
Alkalotic conditions, sir.
So fetal blood is what hemoglobin is there in the fetus?
HB.
Fetal hemoglobin will be
Fetal hemoglobin, always the OD curve is shifted to the left.
left.
That is one thing. Second thing is the acidic products, the metabolic acidic products of the fetal side are released onto the maternal side. So the fetal pH may marginally rise. Any alkalosis will shift the OD curve to the left.
Left.
So this is what is called as double Bohr effect, isn't it? All these acid products that are released to the maternal side again will decrease the pH on the maternal side, shifting the OD curve to the more towards the right. So that is why, it is a double Bohr effect, isn't it? So why should you know about this double Bohr effect again? Can you go against this double Bohr effect with your anesthesia?
It tells about the oxygen delivery.
There is double Bohr effect is there. We know that double Bohr effect is a physiological thing. By providing anesthesia, can you go against this? And you have to keep that in your mind so that you can avoid that. You can prevent it.
Prevent hypoxia to be prevented.
No, hypoxia is not there. No, when you ventilate, if you hyperventilate,
Yes.
Yes, sir.
you are going to produce more respiratory alkalosis. That you are going to shift the OD curve on the maternal side to the
The left.
left. So you are going against the whatever the physiological double Bohr effect, isn't it? So this you should always keep it in mind. Okay, so we'll continue with the other systems like cardiovascular system. Can you just tell what are the changes in cardiovascular system?
Yes, sir.
The cardiac output will be increased to around 40%, 40 to 50%, sir. Where the plasma volume will be increased to 35%, and
Don't go with the only cardiac output means
Yes, sir.
there is stroke volume and
Yes.
heart
rate will be increased to 15 to 20%, and stroke volume will be increased around 30%.
Stroke volume will increase by 40. All you just remember 15-40.
Yes.
Of course, in the books it will be 15 to 25, 20%. So just for the exam purpose, you just remember about these two things, 15 and 40 and 50. Okay, like respiratory rate increases by 15%. Tidal volume will increase by 40%. Annular ventilation will increase by 50%. Now here again, heart rate will increase by 15%. Stroke volume will increase by 40%. Cardiac output will increase by 50%.
Yes.
And then RBC volume will increase by 15%. So plasma volume will increase by 40%. Blood volume will increase by 50%.
50%.
So easy to answer in the exam. If you just remember this rule of 15, 40, 50.
Yes.
Of course, there can be variations definitely in all the books will be there, but answering exam, nobody will say no when you say 15, 40, 50.
Yes.
So just remember this. Okay,
Yes.
so there is going to be increase in cardiac output. Fine.
The systolic and diastolic blood pressures will decrease, sir.
Okay.
Systolic blood pressure by 5 to 10% and diastolic blood pressure by 10 to 20%, sir.
So systolic blood pressure should increase or decrease? Why systolic pressure will decrease? That is older, measurements because of the supine hypertension syndromes.
Yes.
When they were measuring the blood pressures in the supine posture, definitely the pressures will come down. Now, what is happening to the myocardial contractility?
Increase, sir.
Increase.
It is increasing, isn't it? Because myocardial contractility is increasing, there is a decrease in the afterload, and that helps in increasing the myocardial contractility. So if the myocardial contractility is increasing, that is a systole, and that should produce slight marginally raised systolic pressure. And there is peripheral vasodilatation, systemic vascular resistance has come down. So that is the reason diastolic pressures are decreasing.
Decreasing, yes.
So pulse pressure is increasing. That is why you have a forceful apical impulse, and then the increased pulse pressure at the periphery, the pulse volume will be high. That is what is hyperdynamic circulation that occurs in pregnancy. So just remember that there may not be much change in the systolic pressure, or maybe slightly marginally increased, but diastolic pressure will come down because generalized vasodilatation, because of the progesterone, increase in progesterone, and also prostacyclin is increased, producing vasodilatation. Okay, so why you should know that there is an increase in cardiac output and what is the anesthetic implication? And this can be enhanced in case of anemia with pregnancy. Further increase in the cardiac output can occur.
Yes, sir. As a compensatory mechanism in anemia, further increase in cardiac output occurs, sir.
Correct. So why should you know?
Increasing the stroke volume and heart rate.
So what is the anesthetic implication? It is always, whenever you say whatever the change, anesthetic implications are more important. So when you are providing anesthesia, you should be very careful not to decrease this cardiac output. All your anesthetics, whether the type of anesthesia, whether regional anesthesia, general anesthesia, all will decrease the cardiac output. So it's very important that you don't go against this physiological change, isn't it? Our inhalation anesthetic agents can depress, your IV anesthetic agent can depress, your spinal anesthesia, your epidural anesthesia can decrease the cardiac output. So you don't go against this, isn't it? So that is the, because, you know, cardiac output is increased because there is an increased need by the fetus, by the growing uterus, by the growing or enlarging placenta. All these are, you know, require higher cardiac output. That is why there is an increase in cardiac output. Okay, and most important is the supine hypotension syndrome problem, isn't it?
Yes.
Aortocaval compression. So what is the implication of
Yes.
this aortocaval compression and anesthesia?
Again, because of the
Positioning.
IVC compression, the venous return to the heart will reduce, sir. So because of which the cardiac output will reduce, sir.
Lead to hypotension in the patient. So
No, what is the
positioning is
to the baby, isn't it? The baby will suffer.
Yes, sir.
Isn't it?
Fetal
And
hypoxia.
so that is the reason why you don't allow any mother to lie down in the supine posture. You always keep the mothers either in left lateral or 30-degree tilt of the uterus. Though initially we were telling 15-degree tilt, they did not find much improvement in the inferior vena cava dimension with 15-degree tilt. So 30-degree tilt produced maximum dimension of the inferior vena cava. So ideal would be to go for a 30-degree tilt or go for left lateral position. So now, but many of these women, 85% of the women will not develop any signs of decreased cardiac output. What is happening in these 85% of the mothers, and what is the anesthetic implication of this? Why they're coming out with the symptoms of decreased cardiac output? How the blood is reaching the heart?
As a compensatory mechanism, sir. Goes through the baxillary venous plexus and vertebral venous plexus. So the compensation happens, and most 75% of the women don't have any.
No, vertebral, paravertebral veins, and then goes to, from there, how it reaches the heart. Vertebral, paravertebral is fine.
Network issues.
Pardon?
Network issues. We couldn't hear you, sir. 1 minute.
No, how it's going to reach the heart, the right atrium? It has to reach the right atrium, isn't it? The blood.
Yes, sir. Yes.
Passing through the inferior vena cava. Now it is passing through the vertebral and paravertebral veins, and then how
goes to the azygos.
Yes,
Azygos vein, and then it drains into IVC, sir. And then it goes to the right atrium.
Superior vena cava.
Superior vena cava, and then it goes to the heart.
Yeah. That's why I just wanted to ask you, because azygos veins will drain into superior vena cava. So that you should always remember. Now, nothing will pass through the inferior vena cava if the mother is lying down in the supine posture. But the implication is, again, you know, you have enlarged paravertebral and vertebral venous system. So what happens to the pressure there?
Pressure is increasing, sir.
Yeah, positive pressure. So you don't go with a positive pressure technique, negative pressure technique for identifying the epidural space.
Epidural space.
What happens to the, any increase in the incidence of,
there's more chance of bloody tap.
Okay.
And there's increased chance of intravascular placement of the catheter.
So these three things you should always remember about supine hypertension problems. Okay. So let's move on to the gastrointestinal system.
Yes, sir. pregnancy is always considered as a full stomach, sir. So they are more risk for aspiration, and they are more prone for Mendelssohn syndrome. And the gastric pHs will be also reduced for less than 2.5, and the gastric volume transit will be reduced, where the volume will be around more than 25 ml. And the lower esophageal tone will also be reduced because of the gravid uterus, and then it will also precipitate the risk of aspiration, sir. So in order
for
to
Mendelssohn syndrome to occur, what is the minimal pH and then the maximum gastric volume it has been said to be there, which can produce this? pH of?
pH is 2.5.
2.5, sir.
Less than 2.5, and volume more than 25 ml. So who studies studies done by?
Sir, not audible, sir.
Shirley and Maclean.
Sorry, sir, not audible.
No, I'm not audible now. Now is
yes,
it
sir. Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, that is Shirley and Maclean.
Yes, sir.
Shirley and Maclean,
yes,
they did a lot of study and found out, especially in monkeys, rhesus monkeys, they found out this is the minimal pH and maximal gastric volume. And this can be there in all laboring women. What they have found is there is not much decrease in the motility of the stomach in before labor. Once they go into labor, because of the pain, anxiety, the gastric emptying will get delayed. Plus, if we are using any opioids, that will further delay the gastric emptying. That's how, they can have. So that is why all these mothers should be considered as full stomach 1. So rapid sequence induction, if you are going for GA. And the next thing is you have to go for prophylactic drugs to be given.
Anti-aspiration.
Yes, sir.
Again, last time also you said anti-aspiration prophylaxis. So this time also you are telling the same thing, Hema. It is aspiration prophylaxis. It is not anti-aspiration prophylaxis. Because suddenly I remembered you had told the same thing last time. I think you presented thyroid, isn't it? Thyroid, I think you presented. Yeah. So, okay. So it is aspiration prophylaxis. Okay. So now what about the other system? So the hemopoietic system.
Yes, sir. The plasma volume increases by 40 to 50%, sir. The RBC volume increases only by 20 to 30% because of the disproportionate increase. There'll be hemodilution causing physiological anemia of pregnancy, sir.
So what is the advantage of this? Why there should be a physiological anemia?
For the nutritional and supplementation of the
nutritional. See, during labor, what is the amount of blood loss that occurs?
Around 1,000
ml.
No, about 500
ml.
Normal delivery, 500 ml. Yeah, because there is increase in the blood volume, so they can compensate for the blood loss. So second thing is whatever the loss that occurs is a diluted blood because there is a dilutional anemia is there. So more of plasma is lost rather than the RBCs. So there is another second advantage of this particular thing. And the third thing is because the viscosity is decreased, the blood viscosity. So what happens to the flow whenever the viscosity is decreased?
Increases.
Yeah, because Hagen-Poiseuille's law.
Yes.
Flow and viscosity are inversely proportional to each other. Whenever viscosity decreases, flow increases. Like, IV fluids and blood. Blood viscosity is high, so flow will decrease. So here, because the viscosity of the blood decreases, because the RBC volume is much less increased when compared to the plasma volume. So that's an advantage. Okay. So now going into the other systems, the hepatic system and renal system.
Yes, sir. Hepatic system, the enzymes like the AST, ALT, and LDH will be increase.
May or may not increase.
May or may not be increased.
Especially if preeclampsia, then only HELP syndrome. That will increase. But more important is for us
phosphatase,
albumin and pseudocholesterol.
Pseudocholesterol. Yes, sir. Both the levels will be reduced.
So any implication?
Because of which the action of succinylcholine will be prolonged, sir. If the
Yes. How
pseudocholine
much
aspirase comes down.
How much prolonged? No, there will be definitely dilutional decrease in pseudocholesterols.
Yes, sir.
So how much you think that your
15%, sir. 15%.
normally what is the duration of action of succinylcholine? What is the duration of action of succinylcholine?
About 10 to 15 minutes.
No, it is 5 to 7 minutes
40.
maximum.
5%.
Usually it's about 5 minutes. Now here marginally it may rise. It may increase to about 8 minutes to 10 minutes.
8 minutes.
Not significantly, it will not increase. So that is one thing. And albumin levels will decrease. So what is the implication?
Because of which there will be hypoalbuminemia, sir.
It's an
Okay, what is
oncotic
the
pressure and then
For you as anesthesiologist,
drugs bound to the protein will be reduced.
listen, no, the
Binding will be reduced, so there'll be more in the free
concentration.
state, sir.
Free
Free
concentration
form
will
of drugs
decrease.
will be.
So that is another reason why you have to reduce the doses of the drugs what you are going to give, especially drugs bound to albumin. You know that all acidic drugs will get bind to albumin. All basic drugs will bind to which protein? Alpha-1 acid glycoprotein. So what happens to alpha-1 acid glycoprotein levels in pregnancy?
Increases. Increase.
Marginally, they'll
Increase.
So your local anesthetics are bound to alpha-1 acid
Glycoprotein.
isn't it?
Yes, sir.
So one thing, though it may not have much implication as far as your dosing of the local anesthetics is concerned, though because you're going to give reduced doses only, isn't it? Okay. Now renal system again, increased GFR.
GFR and renal blood flow.
Increased creatinine.
Yes.
Normally creatinine will come down.
Yes, sir.
Okay. What about CNS and anesthesia?
So there will be more sensitive to the inhalation agents and sedatives due to the progesterone effect. So the requirement of the volatile agents and the sedatives will be reduced. So the MAC value will be requirement will be less than 30% than the normal, and sedation also will be reduced.
Yes. Okay. The MAC value will reduce because of increase in endorphins and encephalins and progesterone. All these will depress the brain. Because mother can tolerate the pain. For that only, all of them are increased so that the MAC value will decrease. So that is one implication you should know about. So you act as long as you keep that may be sufficient in order to prevent the awareness in these mothers during your general anesthesia. So what happens to the regional anesthesia? Because of the CNS effect, your local anesthetic requirement, you said it is going to be decreased. Why it's going to be decreased? Again, because of the progesterone effect and endorphins and encephalins, which are increased. One. Second thing is pH is marginally increased, isn't it? It may be 7.44.
Yes.
Because of that, more amount of the drug will be in the ionized. Yes. The second thing. And again, the CSF volume is decreased.
Yes.
So low volume.
Epidural volume is increased. Epidural pressure is increased. So that is another reason. And epidural, pad of fat will increase. Yes. Again, the requirement because epidural space for the local anesthetics will decrease. So these are all the reasons that are given. So you might have to reduce by 30%, whatever the regional anesthesia, local anesthetics you'll be using. And again, you may have difficulty to you have your spinal or epidural because the increase in lumbar lordosis.
So it'll be difficult to position them.
Yeah, plus it may go up, whatever the drug you have given. That is another reason why you have to reduce the total dose of local anesthetics, what we use. And the other thing is difficulty in identifying the epidural space because the ligaments are lax. isn't it? The epidural, whatever, the ligament flavum, supraspinous ligament,
Yes.
interspinous ligament, all these will be lax.
Yes.
So you have to be extremely careful.
Lax.
That dural puncture chances are very high. Okay. So I want to just hurry up because, the time factor. Otherwise, I would have asked all these things to you only, the questions. So I had to answer myself. Anyway, now all these are the physiological changes in pregnancy. Okay, now this mother may require, okay, let us say that she has been treated for her iron deficiency anemia, and also, the hemoglobin and hematocrit has been improved. Now, because of, again, I think I have lost you, the net problems. Hello? Hello?
Sorry, sir.
Okay. You don't be sorry at all every time. So anyway, because, let us say that her, everything has been improved. Her, whatever the problem she had, especially the iron deficiency anemia, you have improved her. Now she has reached, full term. And because of some obstetric reasons, they want to do cesarean section, isn't it? So already we have categorized these cesarean sections, isn't it? So how do you
Yes.
categorize these cesareans? Can you just tell the category 1, 2, 3, and 4?
Category 1 is we'll have to take her immediately for the
So
surgery,
what is
sir.
this one? What is this one? Category 1. Why do you want to do an emergency section? There is an immediate threat to the life of
Threat to the
either
life.
mother or the fetus.
For the fetus.
What is category? Immediate threat is there for either the life of the mother or the fetus. So you immediately have to take emergency. You don't have much time. Even minutes also becomes important. That is category 1. What is category 2? Urgent. What is urgent? Now, what is
Urgent
this?
is
where we can
No, what is this? Why urgent? When do you say urgent?
you have to take her for surgery.
No. There is a
For
fetal or maternal compromise.
compromise. Yes.
But it is not producing immediate threat to the life of either.
Yes.
That is category 2, wherein you will have some time, maybe a few hours, maybe 2 or 3 hours you have. That is category 2. What is category 3?
semi-emergency.
Scheduled.
Scheduled.
Category 3, scheduled
Yes.
one, where you want to go for early cesarean section.
Yes.
It is not category 1 or 2. There is no, section you have to do, especially, for example, now ruptured membranes.
Yes.
As early as
Oh, yeah.
possible, 24 hours you have to take up, isn't it?
Yes. Yes.
So there is no compromise as far as the mother or fetus is concerned. Life-threatening problem is also not there. But they do require early cesarean section. So that is what is category 3. It is called as scheduled. And category 4 is elective.
Elective, sir.
Yeah,
Yes.
it's totally elective. So you will have a lot of time. So that's how you
Yes.
have these things. So now, okay, now this is an elective cesarean section. So what anesthetic technique you would like to use for her, and how do you manage?
Sir, I would like to go ahead with single shot spinal epidural, sir. Sorry, spinal anesthesia, sir.
Spinal.
Single shot spinal
Spinal
anesthesia, sir.
Okay, fine. That is the technique you want to use. What are the advantages? Why not GA? What advantages you can have with single shot spinal?
There will be no airway manipulation, sir. Airway manipulation can be avoided.
What manipulation?
Airway
Airway
manipulation, sir.
sir.
Airway manipulation. Okay.
Yes.
One is airway manipulation because it's an extremely difficult airway, majority of pregnant mothers. Okay, that is one. What is the second advantage?
And mother will be awake, and after the delivery, the baby
Aware
can
of
also
the
be
childbirth, sir.
childbirth, sir.
No, just physiological changes of pregnancy. You were telling something again, another problem. You would have gone for rapid sequence induction in these mothers. I think I have lost you again. No, you should have a better network. Hello. So
Yes,
next time
sir.
you should have a better network. Frequently we are losing you. So because you are supposed to take do a rapid sequence
Yes, sir.
induction, isn't it? So why rapid sequence induction? What was the problem? Already we discussed. Aspiration risk, isn't it?
Aspiration risk is there, sir. Yes, sir.
Yeah, one is airway, difficult airway problem you can avoid. Second, aspiration risk you can avoid. Okay. Third thing, you are telling that mother would be awake. So awareness problem is a problem in general anesthesia, isn't it? Because their requirement will decrease, but we don't know. If you are going in for a lower mark, there is always a chance of awareness. So that is another, and you would like to give decreased amount of inhalation anesthetic agents because you don't want any relaxation of the uterus after the delivery of the fetus. So that is another problem. Awareness,
Yes.
intraoperative awareness is a problem which can be avoided by going in for spinal epidural. Okay, what is one more? You're talking about
polypharmacy can be avoided, sir.
yeah, polypharmacy can be avoided. So all these drugs which cross across the uteroplacental circulation, it can be avoided. Okay.
Hemodynamics will be more under control than GA.
Not under control.
Hemodynamic control will be better under GA. That is why if there is a problem with hemodynamic status, we'll always go for GA, isn't it? So that is not bonding between the mother and the fetus. Early bonding, isn't it? You can immediately show the baby to the mother, and many times you can even keep the baby on the chest of the mother. So that contact, the bonding will be better with regional anesthesia when compared to general anesthesia. General anesthesia, it will take time. The mother has to be woken up after everything surgery is over, and the time is unnecessarily get prolonged.
Yes.
Isn't it? So these are some of the advantages. Okay. So disadvantages of spinal?
There'll be sudden hypotension because of a sympathetic blockade, sir. So because of which fetal hypoxia can happen.
No, mother with anemia again.
Yes.
So sudden hypotension, decreased venous return, increased sympathetic block can reduce the cardiac output. So you are going against the whatever the normal physiological changes. That is another very important. One problem is hypotension. So you have to avoid this, isn't it? So how do you avoid this hypotension?
By keeping
after giving spinal
I'll place a Crawford
Pardon?
wedge. I'll place a wedge, sir, of 30-degree elevation in the right upper back, sir.
No, wedge you have to keep whether it is for GA or spinal.
Yes.
Wedge you will be keeping.
We'll give a low dose
nothing to do with. No, low dose means according to the height you would be giving.
Yes, sir.
No, you should have heard about co-loading.
Yes.
And also you must have heard about
Reload.
prophylactic infusions, isn't it? Prophylactic vasopressor infusions. Many times as soon as you administer spinal anesthesia and bring the mother to supine with the wedge underneath the right buttock of say, I've lost or you're there.
And
Yes,
there's
sir.
sir.
Yes,
There's
sir.
sir.
Yeah, you immediately many times you can even start a prophylactic infusion of vasopressors like phenylephrine or ephedrine.
Or ephedrine.
Yes. So till the baby is delivered, so you give prophylactic maybe about 25 to 40 micrograms of phenylephrine every minute.
Yes.
Ephedrine or even noradrenaline continuous infusion till the baby is delivered. Definitely you can prevent hypotension. So this is one thing you should always remember. You don't wait for the hypotension to occur and then treat. Because if hypotension has occurred, so to correct it, it will take some more time.
Yes.
So by the time the baby will develop, hypoxia or
Yes.
ischemia, isn't
Yes.
it? So that is why in exam you can always answer about prophylactic vasopressors also. That is another very important thing. What is the third problem with single shot spine? Disadvantage. I'll give you a clue. Suppose because of some problem, surgery getting prolonged. Surgery is getting prolonged.
Yes, sir.
Yes, sir.
What happens
Sir,
if you have given
adjuvant.
spine?
I'll go ahead with the
No,
adjuvant.
pain.
Adjuvant is
Patient
for
will start feeling pains.
Yeah, so you cannot prolong the
Duration of block.
anesthesia. If you have given a single one more, what is the next problem? What delayed complication the mother can develop?
PDPH.
PDPH, isn't it? So
PDPH.
you just it should come continuously. 1, 2, 3, 4, 5. You just write down these are the points, disadvantages with single shot spine. So once you already written down and then you have known about this, the exam you will be rapidly telling number 1, number 2, number 3, number 4, number 5, isn't it? So these are certain disadvantages with single shot, but 95% of the women we go for single shot spinal because very effective. One more advantage is the success rate.
Yes.
Is very high, 99. So I'll not go into details how you will give, what is the dose, already we have discussed, isn't it? Based on the height, we have discussed 1.4. Even yesterday we were discussing with Mukhtar and Mithun. So 1.4, 1.8 and 2.4 with bupivacaine. And with you, if you want to go for lidocaine, it is 50, 60, 70 milligrams. With lidocaine, 1 ml, 1.2 ml, and then 1.4 ml. 5% lidocaine, which we do not use nowadays.
Yes.
But you may be asked, better you know about it.
Yes.
Okay. Otherwise, in order to, not to have these things, which regional anesthetic technique you can go for? You can go for epidural, isn't it?
Epidural.
Yeah, because epidural, the incidence of hypotension is much less compared to spinal, single shot, because it takes time to attain the sympathetic block and body can compensate for that. And the second thing is, you have a catheter, you can go gradually, you can increase the level of the block. That is another second advantage with epidural. Third advantage, if the surgery gets prolonged, you can always prolong the anesthesia part also. And you can also have post-op analgesia. So these are the advantages of epidural.
Epidural, yes.
Okay. What are the disadvantages of epidural?
Sir, we lost you, sir.
Disadvantages of continuous epidural.
Sir, catheter displacement can happen in.
So first of all, success rate.
Success rate, yes.
Is it same as
no, sir. It's not the same because
definitely it is reduced. It is almost about pregnant mother. So success rate is. Can it give good motor blockade?
No, sir. It's not possible to give good motor
effective motor blockade, and patchy blocks are more common. Isn't it? So that is the problems with epidural, isn't it? So suppose these are the disadvantages. Advantages are, one is post-op analgesia plus no PDPH.
No PDPH.
Isn't it? So, but when you combine spinal and epidural, you can have all the disadvantages of spinal, all the disadvantages of epidural, you can manage, isn't it? With a combined spinal.
Yes.
So that's how combined spinal epidural is also another technique you can use.
Yes.
And when do you go for general anesthesia? Would you like to go for general endotracheal anesthesia, or would you like to go for general anesthesia using a supraglottic airway device, which is ideal?
With endotracheal intubation.
Why not supraglottic airway device?
Because there's increased risk of aspiration at the time of turns.
And your supraglottic airway devices may not be 100% foolproof as far as prevention of aspiration is concerned. Yes. But they can be used as a rescue devices.
Yes, sir.
Isn't it? So, okay, now how do you provide general anesthesia for these mothers? Yesterday, we had already discussed many of the things.
Yes.
That is why we can even cut short about GA for the discussion. So how do you go ahead and then give GA? And I asked you what are the indications? Indications for GA.
If the patient is having any impending cardiac,
No, you can always say category 1.
Category
Yes,
1, yes.
1 cesarean sections.
Yes.
Because life-threatening problem is there for the baby and the mother. You have no time.
Yes.
If you don't have time, it is always better. Rapidly, you can induce anesthesia and the surgery can be managed. Now, you just tell me when you are giving general anesthesia for a pregnant mother, what are the differences of giving general anesthesia to a non-pregnant patient and for pregnant patient? If you just tell the differences, that is more than sufficient. Non-pregnant,
sir,
pregnant.
first thing is, sir, we lost you, sir. Sir, difference between pregnant and non-pregnant.
Non-pregnant, GA. GA.
Yes, yes, sir. First thing, tube selection will be.
No, before that, all these mothers are supposed to be considered as full stomach.
Full
Full
stomach.
stomach, sir.
Rapid sequence
Aspiration.
induction. Even though it is an
Yeah.
elective GA, rapid sequence. Unlike a non-pregnant, why do you want to go for a rapid sequence induction?
Rapid
Not
sequence. Yes.
Isn't it? So there have to be, one is full stomach. So you have to take aspiration prophylaxis and rapid sequence induction. Okay, that is
Induction.
one. Okay.
Considering the
What is the other
airway
difference?
edema of the patient, we have to anticipate difficult airway and keep a difficult airway cart ready, so with smaller size tubes.
Okay, okay, fine. Okay, right. That is the second difference. What is the third difference?
Dosage, drug dosage.
So when are you going to give anesthesia for a non-pregnant mother and a pregnant mother?
For GA, we'll
Is it-
ask the surgeons to be draped and be ready before we start
Isn't it?
inducing the patient.
For a
normal
pregnant
patient.
mother, you ask the obstetrician to, do everything, draping, painting, and
Yes.
holding a scalpel in the hand. About to put on
Yes.
incision, then only you will start inducing. Till then you don't
Yes.
induce. Why this difference?
Because we have to maintain the induction delivery time to less than 20 minutes, sir. Not more than that.
Yeah, decrease the induction delivery time. Whereas in non-pregnant, this problem is not there, isn't it? You can induce and wait for the surgeon to come. So this is
Yes.
one more difference. Okay, what is the next difference? What about the pre-medication? Any difference in the pre-medication?
Yes, sir. We'll have to avoid fentanyl, sir. Because
Yeah, isn't it?
yes, sir.
So in non-pregnant, you would have given pre-medication
Given
of
fentanyl.
opiate. But here you don't give.
Opioids. We don't.
You will,
Yes.
when do you give opioid?
After the
After
baby
the-
delivery.
After the delivery of the neonate, isn't it?
Yes.
So why?
Because
Why?
it can cause respiratory distress in the baby, sir.
Fetus.
Yeah, in order to avoid opioid-induced respiratory depression.
Respiratory distress.
So
Yes.
this is one more difference.
Yes.
Okay, then what else? What more?
Inhalation agent. Inhalation agent requirement will be reduced in pregnant patients. Sir.
So after the delivery of the baby, we'll have to reduce the inhalation agent. You've
So
reduced
till
the
the
MAC.
baby is delivered, till the baby is delivered, what is your flows? How much you keep?
50% O2, 50%
Air. and-
nitrous and
Yeah, so nitrous oxide, you will be using nitrous oxide, you don't use
nitrous oxide, sir. Nitrous
Yeah,
oxide.
so 50-50.
50-50.
Yeah, yesterday I discussed this with
Yeah.
Mithun and why 50-50?
Sir, it acts as an.
No, because there is
It will
increased
help with the
requirement of
faster inductions.
No, it increases requirement of FiO2 for the baby.
Inhalation.
Yes, sir.
That is for the fetus. That's why you go for a higher FiO2
Yes,
of
sir.
0.5.
Yes.
Once you have intubated, now for maintenance, you will go for 50-50 initially till the baby is delivered. After the baby is delivered, you can come back to 30-70.
30-70. Yes.
In a non-pregnant patient, from the beginning only, you go for 30-70.
Yes, sir.
Isn't it? So this
Yes.
is one more difference. Okay. So what other differences?
After
So
the delivery of the baby.
maintaining left lateral tilt throughout, isn't it?
Yes.
Maintaining left lateral tilt again is another difference. In non-pregnant, you need not have to do that. Till the baby is delivered, you have to maintain left lateral tilt of 30 degrees. So that is one more difference. Okay, so anticipating aspiration risk, any particular type of suction you keep ready?
Files.
Yonker suction, sir.
Anchor suction.
Yonker suction.
Anchor suction. What is this anchor suction tip? How it will be?
Rounded, flat, and blunted tips.
It is a wide,
Blunted,
it is a wide mouth
wide or
Yes.
blunted.
and rigid,
Yes.
either made of metal or nowadays we are using the plastic disposable one. You don't use your suction catheters.
Catheters. Yes.
Emergency, suppose if the regurgitation is there, in order to suck as rapidly as possible. That is one more thing. And then again, the para-oxygenation is again another. Routinely, you can go for para-oxygenation of
Yes.
15 liters, or if you can even go for HFNO, or you don't do that routinely for all other women, non-pregnant women, isn't it? There is one more difference. Immediately after the delivery of the fetus, what is one more difference in pregnancies?
We'll have to give uterotonics
Yeah, oxytocin you have to give.
for the oxytocin, sir.
So this is another difference which you will not be doing in
Yes.
non-pregnant mothers.
Non-pregnant.
So these are all the differences as far as GA is concerned. So as long as you know these differences, the other things you'll be knowing how to give GA, isn't it? Plus difficult airway cart that already we have discussed. So video laryngoscopy or even short angled or short handled all those things also will be there. So these are some of the things which you have to know. And again, in a mother with anemia, you have to be careful how you ventilate. Again, normoventilation. Already yesterday we discussed about
Hyperventilation should be
normoventilation. You maintain a PSCO2 of around 30,
30,
ATCO2 of 30 to 35. So that is another thing, because if you hyperventilate, you will produce respiratory alkalosis. You are going to shift the OD curve to the left.
left.
You are going against the double bore effect.
Bore effect, yes.
Isn't it? So these are some of the differences which you should know. Yesterday, we had already discussed about how do you go for post-op analgesia. So all those things has been discussed. So this is how, the discussion regarding the short case of pregnancy done. So any doubts you want to ask? Do we have...
The dosing,
pardon?
the dosing of vecuronium, sir, non-depolarizing muscle relaxant after we give succinylcholine, when should it be given and how much do we give, sir?
No, you give the routine regular dose of vecuronium unless the patient is a preeclamptic mother. In a preeclamptic mother, that too, if the mother is on magnesium sulfate, you have to be extremely careful, because once the mother is on magnesium sulfate, the dose of depolarizing muscle relaxants and non-depolarizing relaxants will be decreased.
Okay.
So yesterday I was discussing, you can even repeat one more dose of succinylcholine, because it is anyway, it is going to be prolonged with magnesium sulfate. They may not require non-depolarizing.
Non-depolarizing.
But routine pregnancy posted for cesarean section without mother on magnesium sulfate, you give the regular dose of say maintenance dose, because already you would have intubated. So you give the ED95, ED95 of vecuronium. What is ED95 of vecuronium? How much? ED95 dose of vecuronium.
0.52.
So because whenever you talk about non-depolarizers, we talk in two terms. One is the intubating dose, another is the maintenance dose. So intubating dose is always twice the ED95.
Okay, sir.
Intubating dose is twice the ED95. Maintenance dose, you have already intubated with succinylcholine. Now the maintenance dose is always ED95. That is why whenever you talk about the dosing in as far as the non-depolarizers are concerned, you should know what is ED95 of each drug. ED95 of acronym is 0.04 to 0.05 milligram per kg body weight. That is why for intubation you go for double that, 0.08 to 0.1 milligram per kg. That is the intubating dose. So ED95 is still 0.04 to 0.05 milligram. That is the one which you give as the first dose, because you already intubated with succinyl choline in pregnant mothers. So she is 50 kgs. So what will be the 50 kg, 0.05 per kg body weight? How much you should give? First dose based on the body weight. We have lost you. So now how much dose you will be giving? 0.05 in 50 kg patient, 2.5 milligrams, isn't it? So plus you will be using inhalation anesthetic agents also. So another 30% reduction will be there. Just you can start with the first dose as you can give in this lady about just 2 milligrams. Don't give routine 4 milligrams for every patient. That is what many times you'll be giving. So you calculate, don't give 4 milligrams. That's what I was telling you, because I think your network issue is there. So you have to calculate for each individual based on the ED95, and that only you should give. And one more thing we did not discuss is you are also telling that as soon as the baby is delivered, you reduce the inhalation anesthetic concentration to 0.5 to 0.7 max. Okay. So any other doubts? We don't have anything in the chat box also. No doubts. Any other doubt? We have another 2-3 minutes.
Sir, there is a question, sir.
Yeah.
Cardiac failure anesthesia management, they have asked, sir, in anemia patient with HB of 4.
No, in pregnancy.
Yes, sir.
Yes, sir.
Pregnancy, cardiac failure, the mother has come with. So it all depends on whether to go for a cesarean section immediately or not. If she is still in cardiac failure, but the upsick indication is not there for cesarean section, you have to optimize the cardiac output. So optimize the cardiac failure. So how do we optimize the cardiac failure? If it is because of it's a high output failure, so you have to optimize the hemoglobin concentration. So you have to be extremely careful in how much of the transfusion you will be giving. So you have to really go for very slow transfusion and with diuretics and continuous monitoring. So you have to, once you optimize the hemoglobin concentration, and also you are going to give some diuretics, you are going to decrease the preload. So definitely you can optimize them. So once you optimize them, it is still better to go for GA in these patients. Okay, that is one thing. And second thing is, if they have to be taken up as immediately for cesarean section, then again you go for GA only, and you cannot give your propofol or your this thing, thiopentone. You go for invasive monitoring, and also you have to go for etomidate. You have to be extremely cautious in using your inhalation anesthetic agents in these mothers, and also keep always the upper torso elevated. And before that, always discuss the problems associated with the complications. There can be intraoperative arrest also, and they do require postoperative management in the ICU. So these are some of the things which you have to keep it in your mind when managing such patients. First, always optimize, try to optimize. But if it is a fetal compromise is there, if it has to be taken up, if it's a category 1 situation, then definitely the higher risk for the mother is always there. So you have to discuss these things with the obstetrician and the patient's attendants, and then only with all the precautions, with invasive monitoring and etomidate, and have to be extremely cautious throughout the intraoperative period. Okay. So any more doubts? That was a very good question. Even many times you can have patients with peripartum cardiomyopathy.
Cardiomyopathy.
Yes.
Not peripartum. Antepartum or whatever, peripartum cardiomyopathy also you can have. So that such patients also, this is the way you will be managing peripartum cardiomyopathy. And again, many mothers developing cardiac arrest. So again, resuscitation also is slightly different. So you have to get into the airway as early as possible, one, because you should not keep on ventilating with a mask. So early intubation, no cricot pressure, and always maintain left lateral tilt. Don't take any anti-lines in the lower limbs, always upper limbs. And, peripartum cesarean section to be done within 5 minutes.
5 minutes.
5 minutes.
Yes.
These are some of the differences as far as the collapse of the mother or cardiac arrest in a mother. Okay, so one more thing we should have discussed is, local anesthetic systemic toxicity when you are providing labor analgesia. So that if time is there, we'll discuss in the next class.
Okay, sir.
Already, I think it is more than 7:03. Any more doubts regarding anything? Anybody has?
Nothing,
No,
sir.
sir. No chat box.
Okay, then very nice. We had a